whenever I tell my experience, I always like to say I was in the kindergarten to work program. So maybe you were in that same program. But he's at the national level been involved in healthcare quality and specifically working with CAHPS survey. He directs the national CAHPS database, which was designed to support benchmarking of CAHPS. And they have, he's going to tell you about CAHPS improvement stuff they have. But he's really here to talk about why CAHPS, what's going on at the national level. We feel so fortunate to have Dale with us today. So, Dale.
Thank you very much. Well, thank you for the opportunity and to the leadership at Q-Corp for bringing me out here. I think Aaron said it really well this morning earlier that if you need a really good reason to do CAHPS, you don't have to look any further than it's just the right thing to do because the patient's voice matters. And we have a lot of evidence, a growing amount of evidence that doing things that focus on the patient experience and improving the patient experience has a lot of correlation with other good outcomes, whether they be clinical or business related. So the bottom line is it's an important thing to undertake. But beyond that, and what I was specifically asked to talk about today is the landscape nationally and other drivers or forces at work that create even further good reasons to focus on patient experience, and particularly the CG-CAHPS set of instruments, and even more particularly the PCMH version of CG-CAHPS. So what I'm going to do today is quickly walk through the elements of this very dynamic landscape of patient experience survey measures, how requirements for doing CG-CAHPS, clinician group CAHPS survey in particular, are expanding to be driven by public reporting, pay for performance, practice recognition, physician certification, quality improvement demands, and what are some of the policy implications of all of those things for what you're doing locally in Oregon. So the first and kind of overriding point is there is a lot going on out there with respect to CAHPS in general. CG-CAHPS is our particular focus today, but since CAHPS started back in 1995, it was originally a single health plan instrument which was designed to capture the experiences of enrollees in managed care plans or the fee-for-service sector. Since then, it has absolutely exploded, and particularly because of the Affordable Care Act, we have now literally 24 CAHPS instruments that are either developed or in development and testing. With respect to ambulatory CAHPS, we have this continued focus now on the clinician group level because of internal demands to improve, to tie patient experience scores to compensation within the group. We have these external demands for reporting and accountability related to the various forces I'm going to talk about in a moment. And what that has led us to do is the CAHPS Consortium. And I wear multiple hats within this CAHPS enterprise. But we have responded by creating a couple of different versions of CG-CAHPS to respond to these different needs. We have a 12-month version, we have a visit version, and then we have a ton of what we call supplemental item sets. And actually what the PCMH CAHPS survey is actually the core 12-month version with a set of supplemental questions added to it that specifically address aspects of the patient-centered medical home. There are other supplemental sets. One has to do with health literacy and how well a practice is responding to the demands of challenged populations with respect to language. We have a set of questions that deal with cultural competence and how well the practice and providers are dealing with vulnerable populations and dealing with different cultural diverse patients that access the practice. We have a health IT set that is available and a lot more. And one thing I'm going to just mention, because it's actually the focus of what I'm doing a lot of now, the idea of your desire, your interest in open-ended questions is something we've heard more of. CAHPS is focused on closed-ended questions primarily because we do calculations, we do scores, we do comparative benchmarks and analysis. But we're doing more research now on how to collect verbatim responses from patients more scientifically because there's a lot of competing landscape in terms of public reporting. We have kind of the sort of more scientific, metric-driven reports out there, but there are a lot, as you know, of online reporting rating services, Angie's List, health grades, you name it. There are expanding numbers of websites that are appealing to a lot of people because of the anecdotal, the verbatim nature of the comments. And so our challenge with CAHPS moving forward, and this is just kind of a plug for some of the future directions that we're taking, is to figure out how to better collect those kinds of verbatim responses from patients in a more systematic way. And then, once we do that, how can you report those narrative comments to complement these kind of close-ended scores that we've been traditionally focusing on. So this is a grid that I'm sure you can all see. I had sent a little couple of briefs that we've written that we can send you any of this information in greater depth. What I really want to do with this table is illustrate that within the CG-CAHPS world, there's really three fundamental surveys that people are focusing on today. One is what we call the 12-month, the other is the visit, and as I mentioned, the PCMH survey is really the 12-month plus additional items added to get at aspects of the medical home. There's comparability, and this is important, I think, for those groups in the state that may be using one or another of these versions. There's direct comparability on some of these domains, particularly the access domain, which is written in the 12-month time frame across all versions. So even though you're using a visit version here and maybe somebody else is using PCMH, if you want to get to comparability across multiple groups in the same market, using these different versions, you can do it on the access domain, you can do it on the provider rating, and you can actually do it on the recommended provider. So there's a lot of detail here, we won't go into it, and this is not meant to be a CAHPS primer, but I'll be around to answer any of those questions that you might have as we go through the day. So from the big picture nationally, we have an emerging consensus, which has been driven a lot by the National Quality Forum, who endorsed the CG-CAHPS instrument back in 2007. And since then, a number of other initiatives that have been advising the Secretary of Health and Human Services have come out with very strong endorsements and encouragement to use CG-CAHPS. One is the National Priorities Partnership, which has a work group, a number of work groups. One on consumer and family engagement has specifically advocated the use of CG-CAHPS as its top priority. And something called the Measure Applications Partnership, or the MAP, which is advising, again, the Secretary of HHS on how to get to sort of common elements of measurement across multiple programs, both public and private, has endorsed or recommended the use of CG-CAHPS in all clinician performance measurement programs. So there's sort of widespread national sort of level support for moving in the direction of CG-CAHPS. So a number of the drivers that I mentioned at the very beginning have flown out of that kind of strategic direction, out of sort of these national multi-stakeholder organizations that work on consensus. Public reporting is clearly a big driver. Oregon is one of 16 aligning forces for quality programs. Around the country, there's the ARC-sponsored Chartered Value Learning Exchanges. There's 24 of those. And one that you'll be seeing more of is the Medicare-sponsored Physician Compare site, which currently is not great, and I know needs to get a lot better, and it's under a lot of pressure to get better very fast because of the Affordable Care Act. They are supposed to be naming how they are going to build patient experience into Physician Compare in 2013, and by 2014 it's supposed to be actually on Physician Compare. And what they're going to use for this, we think, is a version of CG-CAHPS specifically designed to assess group level performance, and these are larger groups because those who are reporting through PQRS tend to be larger medical groups of 20 or so clinicians in the group. And it'll be voluntary, but there will be incentives to report just as there are for other PQRS measures, Physician Quality Reporting System measures. So we have a lot of public reporting at work at the federal and the state level. And just to position you in Oregon relative to your counterparts in other communities, 9 of those 16 aligning forces for quality programs have done some kind of public reporting already with CG-CAHPS. And it varies quite a bit in terms of the versions they've used and the level at which the data have been collected and reported. 2 of these markets, Kansas City and Memphis, have sampled at the individual physician level and reported that information that way using the 12-month survey. Minnesota, Wisconsin, and Detroit have used the visit version of the CG-CAHPS and reported at the site level. The others that you see there, Puget Sound, Massachusetts, Humboldt County, and Maine is probably the closest to what you're doing now because they are just getting out of the field, having implemented with a state subsidy support the PCMH version for adults and pediatric patients, and also a 12-month version for specialty clinics, and we'll be publicly reporting that information in August. So you're not alone. You've got good company in this process, and I understand that public reporting will be coming soon to your market. And I don't want to steal anybody's thunder. I believe there are some outlines of some sort of wireframes already developed in terms of how those brave pioneer pilot clinics have collected data, how their information actually might be at least in the sort of beginning steps publicly reported in the state of Oregon. So as with HCAHPS, hospital CAHPS, which started as a public reporting initiative by CMS that kind of graduated to not just pay for reporting, it is now pay for performance related to how well you do on HCAHPS. And the formula is giving 30% of this sort of at-stake amount of compensation at the hospital level to HCAHPS as part of this sort of scheme of metrics that are used to assess your performance. So I think that's a harbinger of what's to come in the ambulatory market. We have evidence of that in several ways. One is the big Medicare Shared Savings Program. Are there any ACOs in the Oregon market represented in the room?
There's only one ACO.
In Oregon? Okay. So this probably does not directly affect you, but there is a very explicit tie to performance based on CG-CAHPS if you are an ACO. It's one of the sort of 30 or so metrics that are being used to decide what amount of savings you'll get back through this shared savings program. I know another initiative is very directly related to what's going on in Oregon, and Jeanene, you may be talking about this. It's the Comprehensive Primary Care CPC initiative, where CMS is working in 7 markets. Oregon is one of those, with primary care practices to implement the patient-centered medical home survey as part of this transformation process over the next 5 years. This is huge for you in Oregon. I think it's a big opportunity for you to leverage federal dollars that are going to be used, because this is not just Medicare patients. This is the full sort of spectrum of patients in the population of these primary care practices will be included in the survey, and the feds are going to pay for it over a period of 4 years, once a year. So I think that's a great boon for those of you in Oregon. And then in other markets, and I don't know if this is true in Oregon, but you may have some experience or insights to add yourself, is that private health plans, commercial health plans, are beginning to use CG-CAHPS in doing some kind of pay for performance directly with the medical groups that they contract with. That's been true in California for years. It's true in Massachusetts with Blue Cross. There's several health plans in Michigan that are tying their compensation or their contract arrangements to medical groups directly to performance on CG-CAHPS. So you have reporting publicly that has led to pay for performance. And so we have another element that's going on that I'm sure you're familiar with, which is certification or recognition. And so this is another external incentive driving the market toward CG-CAHPS. NCQA started this ball rolling. In fact, CAHPS partnered really closely with NCQA to develop the patient-centered medical home version that has been pilot tested in Oregon for use in their distinction in patient experience reporting. It's voluntary at this point, but if you collect PCMH and you're seeking NCQA recognition for patient-centered medical home, this gives you extra points. HRSA, which deals with federally qualified health centers, is also working in a pilot, it's a national pilot involving 500 centers around the country, trying to support them to achieve NCQA recognition, and the Patient-Centered Medical Home Survey is going to be part of that in terms of their evaluation of the effectiveness of the program. Then one other piece here that's kind of getting close to the clinicians in the room, and this is a little bit of a wild card. In 2009, the American Board of Medical Specialties adopted a whole new set of maintenance and certification requirements, and this is where physicians get board certified, and then they have to recertify every 10 years or 7 years, and that's probably changing too. But as part of that casting of MOC, they decided to choose the doctor communication domain, which is part of the core set of CAHPS surveys, as a developmental standard that can meet the communication skills and assessment requirements for board certification. ABMS is the umbrella over 24 individual boards like internal medicine, pediatrics, cardiology, and all the rest. Each of those is developing its own way to build this into their MOC. And there are two leading boards, ABIM, and I think it's the radiologists that have actually moved farthest to get this built in. But it's actually something that's, if this were to really gain traction in certification, this is huge in terms of the impact, because it's one thing to do hospitals, and there's 4,500 of those. Then you get to medical groups, and there's several 100,000. You get to the individual clinicians. We're talking about huge numbers of clinicians being affected by this requirement, if it actually expands to the scope that it potentially could. Just so you know, these two are kind of closed systems, but in most markets there's a VA, most large markets. Is there one in Oregon? Yeah. Okay. So you should know that they have moved internally to using the PCMH survey for surveying all of the veterans that visit their facilities. And so they have a ton of surveys they've collected across these 900 sites of care across the country. And a couple of years ago, the Department of Defense moved to this with their TRICARE program, which does both inpatient and ambulatory care. They contract with private purchase facilities for some of their care, and they also have specifically dedicated military centers. So you've got the kind of private healthcare system with all this activity in terms of reporting and pay for performance and what Medicare is doing, but even in these sort of closed systems of the VA and the Department of Defense, they're all actively working with some version of CG-CAHPS. So just to kind of bring this home to, so what does this mean if you are a large health system? And I'm just using one system in Minnesota that I know pretty well. It's called Alina. They are actually dealing with this whole issue of multiple requirements. And if you look at this picture, it just shows you, without getting into all the details, that there's a lot of things coming their way. We have the Minnesota Community Measurement, which is your counterpart, the Q-Corp's counterpart in the state of Minnesota, has done a voluntary initiative with CG-CAHPS since 2008. The state of Minnesota, as part of its health reform that preceded the ACA, decided to mandate the use of the visit survey in all clinics in the state of a certain size. So you have the visit survey being now mandated by the state of Minnesota. We have a health reform division that's focused on patient home, that we call it the health home in Minnesota for certification, looking for the PCMH version. You have CMS, Alina is a big ACO, looking for the ACO version. You have NCQA looking for the PCMH version. And all of this is impinging on one organization. And they're just saying, help. How can we begin to respond to all of these multiple requirements and make sense of it? Which leads to my final point, which is the good news is that these initiatives, which I sort of run through at the national level, are centering around some form of CG-CAHPS at the practice site level for public reporting and pay for performance. We certainly need, because of this illustration just a moment ago, we certainly need in Minnesota and Oregon and every market greater alignment of all of these requirements to reduce the burden on respondents, because we're actually facing tough situations now. The question about response rates came up earlier this morning, and we think now that a response rate of 40% is good. Well, I mean, what you really want is much higher, twice that in terms of really good response rates, and we're not getting those anymore. We're burning patients out. We're running out of sample because we're running so many different surveys. And that's a burden on patients and the healthcare organizations, their budgets. You know that better than I do. And if we're gonna actually get to some standardization to improve the comparability of the results we're getting, we really need to be better aligned. I think you're on the right track in Oregon with the patient-centered medical home version. And I say that because of all the reasons I just mentioned in terms of the direction things are headed, and building on that as a chassis for what you do to line up with state and federal requirements gives you then sort of, I think, the freedom or the sort of the flexibility internally to do whatever you're doing in a way that maps to the patient-centered medical home survey, even if you're not using that as your ongoing internal survey for, you know, basically what you do as a normal business operation. And all of this is going to get much easier for patients and providers alike when we get to some better, more cost-effective ways of collecting these data. And we're working on that, and we feel that, you know, modes like email administration is very promising for those who have email addresses. We're actually looking at new ways of doing point-of-service data collection with tablets, which, if we could figure out a way to do that reliably, would be a huge breakthrough for lots of reasons: cost, accessibility for hard-to-reach populations, and just tons of other reasons. So that's a quick walk through the national landscape, and I don't know if you want to take questions now, or should we just move to Jeanene?
Maybe we'll do it at the end, and I'll
Sure.
introduce Jeanene. One thing, Dale, just I might ask you to elaborate on that you talked about this morning. One of the great things about hearing how much is going on nationally is, you know, usually we're on the cutting edge in Oregon. There's no examples to follow. There is a lot of good information out there, and Dale, you referenced this morning the improvement guide. Could you talk about that just for a second?
The CAHPS Consortium has developed a number of tools. They're free on the CAHPS website, and I could give you the URL, but it would just be easier to Google CAHPS, and it'll take you there. If you go there today, you probably won't find it because it's been down for the last 6 months. It'll be up by the end of this month. But there we have the CAHPS Improvement Guide, which is designed, you know, to support medical groups primarily in identifying ways that they could intervene to improve their scores in these specific domains. We have case examples written up. We have a number of podcasts on different aspects of improving the patient experience, and you'd find a lot of resources, again, free, public domain, once the site is back in operation. That's a little plug
Great.
for that.
Thank you so much, Dale. So now we heard a little bit about the national level, and now I'd like to introduce Jeanene Smith, and I'm standing right in front of her. So Jeanene Smith is the Chief Medical Officer for the Oregon Health Authority, and she's also the Administrator for the Oregon Health Policy and Research Division. And the great thing about Jeanene is she's still a practicing physician, correct, in the miniature.
spare time.
She actually is experiencing all the things that are happening in Oregon herself. Jeanene plays a critical role in she's been with the Oregon Health Authority since 2000, right? And so she's been very involved in Oregon Health Plan, and certainly in the last few years where we've been really focused on transformation and the development of the CCOs. So now Jeanene is going to share with us kind of what's happening at the state level and what can we expect to see in Oregon related to CG-CAHPS. So, Jeanene.
Thanks very much. I've been the Chief Medical Officer for a whole week, so I don't know exactly. It's sort of a new title, some of the same job, most of the same job, plus a few other things. So we'll see how this goes. So I think Dale is at a really nice stage of how important CAHPS is, and I just wanted to touch on a few aspects from the state perspective. And when I can't answer a question, I know Don Creech is here, who is part of our patient-centered home certification program, can give you a lot more detail than I can. So many of you are probably aware of the state's efforts to have sort of a common definition for a patient-centered home or medical home. So we, several years ago, went through our usual Oregon public process to land on the standards that were set. NCQA was good, but not quite good enough at that time. And 2011 was a little better. And who knows, someday maybe we'll be right in sync. But at this point, we have our own set of standards for Oregon, although you do get credit for NCQA certification as part of it. There's a few additional things. But we set up a program to certify. We partner actually with the Quality Corporation on many things related to this, including the actual certification portal that links out to some of the population health metrics. And the idea is to work with all of you to help you all to succeed. And we've also, with Susan's being at the helm of our new Patient-Centered Primary Care Institute, working to try to help practices be successful at achieving the new model of change and working their way up through the tiers. The idea behind it was really that if we could all have a common agreed upon standard, then ODS, Providence, Regents, CCOs now, anyone could kind of know, okay, that's a patient-centered home, and could decide how to pay and encourage further spread of the model across their provider networks, and they up to them how they might pay those particular tiers, with us doing our own as we can through Medicaid. But as you all probably who have done this know that there's sort of 6 core attributes. We tried to think of these more from the side of the patient. So, the access to care is more like be there when I need you to be there for my family, rather than the next available appointment, blah, blah, blah. So, so inside of each of these 6 core attributes are a set of standards that have been actually continuously sort of re-examined since they were first laid out. And there's 2 of them that include the CAHPS as an optional approach to be able to succeed at them. And again, a tier 1 is kind of when we first talked about this, Robbie Laws, who's a provider on the coast, said, this is kind of like what I do. And so it's kind of like what kind of sort of the base that someone could become. Tier 2 is a little more of a stretch, a little bit of a change. Tier 3 is the more ultimate change. And then we anticipate the standards to be kind of constantly moving and making that 2 a little harder, a 3 a little harder, and just continuing to inspire and incentivize, ideally with the partners of the payers, to incentivize that change. So then the ultimate goal was laid out that we would want to see all of the Oregon Health Authority, which now purchases for almost 1 million people at this point in time, and after 2014, a whole lot more. But between our Medicaid program, our Public Employees and Benefit Plan, the Oregon Educators Board, and the current subsidy programs that will probably then blend into the new exchange, how could we really inspire this through our sort of purchasing power that the state has? Like, this is what we want to see, and we really want to pay for the outcomes. We don't really want to get into exactly whether you have 5 doctors and 1 electronic health record, but we want to see that the outcomes delivered to the patient and the family is what improves their health and keeps them managing their healthcare problems. And so the goal is really to try to do this across all lines of coverage that the health authority can touch, and then partner with our private payers, as we're doing with Medicare in the CPCI. How can we work with the other payers to kind of all do this together? So the 2 patient-centered primary care home standards that have a linkage to CAHPS at the current time is the access to care, and access to care is broken up into a couple of standards, and one being the in-person contact, and the other one being person and family-centered care, and what's the experience of care. And CAHPS is at this point optional, and we aren't really dictating exactly what version at this point, but that idea is that you're getting that experience of care, not just so you can report it to someone. In fact, we actually don't want to see the results. We want you to use them to be able to improve the experience of care for the patient. Again, we want to pay and incentivize the outcome and not necessarily dictate to you how to do it, but that the CAHPS is a good tool. And I think from listening to Dale and all the efforts there is, you know, as we move to kind of improve and refine the standards over time, you could see going forward that there might be more collective effort to try to do a particular patient-centered medical home version so that you can really capture that. And we know there aren't super great metrics at this point for all aspects of care coordination and collaboration. We've certainly had that discussion with CMS lately as we went through our waiver negotiations. But we're going to all kind of work on this together to better capture is what is good care coordination, what is building that relationship with the patient, and how do we measure that enough to be able to show folks what good work all of you are doing. So, you know, we really want to help the clinic and the patient understand their perception of the clinic's care. And eventually, it is also a means for statewide comparison, not unlike what the feds are wanting to do from a national side as well. And, you know, as I said, they're not necessarily required to do any one at this point, but they need to attest, and we're doing some site visits to go and see what they're doing and how they're doing it, and we'll continue to learn from that going forward. You could anticipate maybe at some point in time we would actually require it, but it is really important and critical to achieve those higher tiers, and if you get the higher tiers, then ideally the payers would encourage that by paying better. You also might have noticed that we have this transformation going on, the governor's vision to transform the delivery system around the triple aim. And so there has been a tremendous amount of work in a very short period of time. It's really built upon the foundations Oregon has always had. It's really starting in the Medicaid program around coordinated care. We now, as of, I guess, November, have 90% of the Medicaid population in a coordinated care organization. Pretty amazing in 3 months to move 600,000 people into these. And some of the fee-for-service folks also were folded in. Perhaps not everything was perfect, but it's off and running. The idea is to really build on that, but patient-centered home and primary care is really a foundation to that. So most of you probably know what this is, but in case you don't, it is different than an accountable care organization. And Elliot Fisher said that he thought coordinated care was a better name for what we all want to do anyway. Who wants to be managed by accountants? Wouldn't you rather be managed by coordinators? But he said he was trying to get a coordinated care into the ACA. I said, oh, well, we did it here in Oregon. The difference being is that it is really a risk-bearing entity, and it is very statutorily required how that entity is formed, who's on their governance, how do they work with their community, and their requirements. And so we're in some ways using that contractual purchasing power that the state has over Medicaid to be able to try to drive this change. There is supposed to be a primary care and a behavioral health person on their governance structure. They need to be working with their local public health and mental health entities. And there, as I said, now 15 of these around the state. They're all, you've seen one CCO, you've seen another, you've seen one CCO. They're very different. There's a couple in some areas, but most of the state there's just one. And it really is bringing together all of the delivery systems in those areas. And the idea is that we are really holding them accountable and asking for that care to be coordinated. The relationships with the old previously existing managed care organizations are at this point basically null and void pretty much. Eventually the dental care will be folded into this as well. So there's key levers that were developed, and a lot of them are around this sort of fixed global budget that they will be held to. And us holding them accountable with metrics and measurements. And there's quite a few of them, and of which it's more on a plan level, but CAHPS is also part of that. So the deal the governor laid out with CMS, which most of the other governors haven't quite jumped on the bandwagon for this, is that for an investment of $1.9 billion, that we would reduce the cost trend in Medicaid by 2%, so that at this point we're starting at about a 5.4%. It'll be 4.4 this next year, and then hold steady for the rest of the waiver at 3.4. But at the same time, we are supposed to be assessing and monitoring the quality, and the feds do not want to see a decline in quality, and part of the quality measures are the patient's experience of care. And they also want to see that the population is improving, and that we want to get good data back from the plans about what they're doing. And we've established a quality pool that is also linked to CAHPS. So these are sort of the sort of areas. There's, I think there's about 100 performance measures overall, 33 metrics, 7 areas. But you'll notice that primary care for all populations is a key aspect of that. And the states' deal with the federal government is, you do this or else you pay us the money back. The money is to be invested in the delivery system to help spur this along. But so we're being held accountable, you know, between the feds and the state. And then at the same time, we are holding the CCOs accountable. The CCOs will obviously need to be working closely with their provider networks to be successful at this. So this really is trying to move payment from just the widget sort of fee-for-service to really paying in more of a pay-for-value approach, and that we would create a quality pool so that here's your fixed budget CCO, and if you do really well on these areas and they've been identified by a sort of separate statutorily required metrics and scoring committee, you can get some additional dollars to fuel your transformation. And there's 17 key metrics, of which one of them is the spread of patient-centered primary care homes. The more 2s and 3s you have in your network, the more you can get back out of your quality pool. In addition to the things that we also know will keep costs down, improve health care and health is, you know, we're focusing on chronic diseases, behavioral health integration, reducing hospitalizations. So the money will be distributed on a yearly basis to the CCOs, and it'll be based on those 17 criteria, based on their performance. So how does this tie back to CAHPS? That there will be some composite CAHPS scores. They're more the health plan level. We've always done CAHPS with Medicaid on the health plan level, but they will be held accountable. There'll be a composite score across the kids and adults around these 2 areas of access to care and satisfaction. But they can, they will also be reported to CMS per our requirements to be reported. So again, at the plan level, there'll be CAHPS, and then patient-centered home standards it's encouraged to do CAHPS. And we hope that then, therefore, the health plans, besides just the CCOs, will be encouraged to look at that patient satisfaction effort that you're making and reward you. So on all of it, will at this point, as the health plan level data will be publicly reported. As I said, in the patient-centered home at this point, you not necessarily need to report your findings or what your patient satisfaction is at this point. But you're being rewarded on a tier 1, tier 2, or tier 3 basis, which is publicly reported.
And you can imagine the day that patient experience will be publicly reported, because clinical is publicly reported, soon costs will be. So if you think of the triple
It
aims.
potentially could be.
Yeah.
And then, as the governor's vision is to take this not just to stay in Medicaid, but how can we do it through our state public employees purchasing? How can our relationship with whatever vendor? It doesn't mean that we're going to put a state employee in a CCO per se, but we're going to open the bid. The application will look fairly similar to wanting some of the similar kind of metrics and measurements from whoever we would decide to purchase from for PEB. The multi-payer, which I forgot to put the slide in on, but the CPCI is a nice bonus of that, is those 60-some clinics. The feds are actually picking up the cost for CAHPS across those clinics, and that's an interesting model that we might want to think about. There's 5 payers in there, Regents, Providence, Tuality and Care Oregon, and and our small number of fee-for-service lives are in there. So that's a start on sort of doing a group effort in terms of the CAHPS survey. And I think then additionally, the governor's had conversations with some of the health plans and starting to have more about how can we fold this coordinated care model into how we design what a qualified health plan is. We know that they're rushing to get the exchange up. It's going to touch anywhere from 200 to 300 some folks. How can we maybe think of ways that that can be folded into those benefit design, and what's the criteria on what's a really, plan that you'd want to help drive people to because it's doing good care, and the CAHPS being a critical part of that. So with that, I will stop, but if you want to read like thousands of pages about metrics, the terms and conditions of the waiver is that first accountability plan. And then most of you, Dawn is here if there's questions about the standards themselves, but there's lots of information there too.